Varcarolis, Chapter 22, Substance-Related and Addictive Disorders. Key terms and concepts: addiction, codependence, co-occurring disorders, intoxication, patient-centered care, screening, brief intervention, referral to treatment, SBIRT, substance use disorder, tolerance, withdrawal. Substance use disorders are not disorders of choice. They are complex diseases of the brain characterized by craving, seeking, and using regardless of consequences. Continuous substance use results in actual changes in the brain structure and brain function. Substance use disorders are chronic and relapsing. They result in compromised executive function circuits that mediate self-control and decision-making. Historically, substance use disorders and psychiatric disorders were treated in separate systems of care. Individuals received care for mental health problems in the psychiatric system, while treatment for substance disorders took place in specialized chemical dependency units or separate facilities. If both mental health and substance use disorders were present, the treatment might occur concurrently in different settings or as back-to-back treatment in one system followed by the other. Currently, the trend is to integrate treatment, and facilities increasingly provide services for co-occurring disorders. Due to the magnitude of substance use disorders, agencies at the national level have been created to address them. The lead federal agency devoted to research regarding drug use is the National Institute on Drug Abuse, NIDA. Its mission is to advance science on the causes and consequences of drug use and abuse and to apply that knowledge to improve individual and public health. The Substance Abuse and Mental Health Administration, SAMHSA, serves a dual mission of reducing the impact of substance use and mental illness on communities in the United States. It is important for all nurses, regardless of their practice specialty area, to develop an understanding of the complex disease of substance use disorders. In this chapter, you will be provided with an overall picture of substance use disorders, concepts central to this problem, and risk factors for its development. We will review the clinical picture for each of the substances and discuss associated treatment. Finally, we focus specifically on alcohol use disorder and apply the nursing process to it. In 2013, the American Psychiatric Association replaced the categories of substance abuse and substance dependence with a single category, substance use disorder. A SUD is a pathological use of a substance that leads to a disorder of use. Symptoms fall into four major groupings: impaired control, social impairment, risky use, physical effects, i.e. intoxication, tolerance, and withdrawal. SUDs encompass a broad range of products that human beings take into their bodies through various means: swallowing, inhaling, injecting. They range from fairly innocuous and innocent-seeming substances, such as caffeine, to absolutely illegal mind-altering drugs, such as LSD. No matter the substance, use disorders share many commonalities, intoxication characteristics, and withdrawal attributes. The DSM-5 provides diagnostic criteria for the following psychoactive substances: alcohol, caffeine, cannabis, hallucinogen, inhalant, opioid, sedative, hypnotic, and anti-anxiety medication, stimulant, and tobacco. In addition to substances, behaviors too are gradually being recognized as addictive. These behavioral addictions are called process addictions. In process addictions, there are no substances, but rather a behavior or the feeling brought about by the relevant action. While the physical signs of drug addiction do not accompany these types of addictions, compulsive actions activate the reward or pleasure pathways in the brain, similarly to substances. The first process addiction, gambling, was officially declared a disorder in 2013. Internet gaming, using social media, shopping, and sexual activity are also process addictions. Addiction. A term that people commonly use to describe substance use disorder is addiction. Addiction is defined as a primary chronic disease of brain reward, motivation, memory, and related circuitry. It is a disease of dysregulation in the hedonic or reward pathway of the brain. Addicted individuals are unable to consistently abstain from the substance or activity. They are also unable to recognize the extent to which the addictions are creating serious problems in functioning, interpersonal relationships, and emotional responses. Like other chronic diseases, there are cycles of relapse and remission. Ultimately, without treatment, addiction is progressive and often results in disability or premature death. When people are in the process of using a substance to excess, they are experiencing intoxication. Intoxication may manifest itself in a variety of ways depending on the physiological response of the body to the substance being used. Individuals who are using substances are considered to be under the influence, intoxicated, or high. Terminology may vary depending on the substance and the population who is using it. Alcohol causes intoxication, but cocaine makes you high. People with substance use disorders experience tolerance to the effects of the substances. Tolerance occurs when a person no longer responds to the drug in the way that the person initially responded. It takes a higher dose of the drug to achieve the same level of response achieved initially. Withdrawal is a set of physiological symptoms that occur when a person stops using a substance. Withdrawal is specific to the substance being used, and each substance will have its own characteristic syndrome. Substance-specific withdrawal can be mild or life-threatening. The same substance, or one with a similar action, may be taken to avoid or relieve withdrawal symptoms. The more intense symptoms a person has, the more likely the person is to start using the substance again to avoid the symptoms. Behavioral addictions such as gambling seldom have clearly identifiable intoxication or withdrawal symptoms. Epidemiology. The National Survey on Drug Use and Health Survey is conducted annually. Participants 12 years or older are randomly asked to participate. Data from the survey are the primary source for national drug use statistics and trending. Based on the survey, more than 21 million individuals, or nearly 9% of the population of the U.S., are estimated to have SUDs. In 2014, nearly 140 million people, about 53% of the nation's population, acknowledge drinking alcohol. About 60 million people, 23%, admit to binge drinking. Binge drinking is defined as 5 drinks on one occasion on one day in the last month. About 16 million people, or 6%, report heavy drinking. Heavy drinking is defined as 5 drinks on one occasion on at least 5 days in the last month. According to the 2014 survey, 27 million Americans, or about 10% of the population, used illicit substances in the month before the survey. Illicit substances include the non-medical or non-prescribed use of prescription drugs. Illicit drugs use in 2014 for individuals 12 to 17 years old was about 9%. For individuals aged 18 to 25, the rate was highest at 22%. For adults 26 years or older, the rate was slightly more than in previous years at 8%. In 2014, marijuana and non-medical prescription pain relievers were the illicit drugs of choice. About 22 million individuals reported using marijuana in the past 30 days. Although the use of most types of illicit drugs has not increased in recent years, an overall increase in illicit drug use seems to be attributable to marijuana. The percentage of people aged 12 or older in 2014 who are current marijuana users, 8%, was greater than the percentage in 2002 to 2013. In addition, the estimate of marijuana use was greater in 2014 than the estimates in 2002 to 2009 for young adults aged 18 to 25 and 2002 to 2013 for adults aged 26 or older. In the 2014 survey, more than 4 million people reported non-medical use of prescription pain relievers. It is the rise of prescription drug misuse that has prompted the greatest concern. Non-medical use of stimulants, including amphetamine and Adderall and Ritalin, has more than doubled in the past few years. The use of synthetic drugs, e-cigarettes, and hookah are on the rise among young adults. There's a box. Government response to prescription drug misuse. In the United States, more than 120 people die every day as a result of drug overdose. Surprisingly, deaths due to controlled prescription drugs have outpaced those for cocaine and heroin combined. The main source for these drugs are friends or relatives who have legitimate prescriptions. Ultimately, prescription drug use may also lead to the use of heroin, which is less expensive, easier to get. Unused drugs that find their way into the hands of people with use disorders are a real problem. In response, the DEA began hosting the National Prescription Drug Take-Back Day initiative. This initiative provides a safe, convenient, reliable way for disposing of unneeded prescription drugs. As of 2016, when 6.4 million pounds of medication had been collected during the first 11 take-back days. Scheduled drugs. Drugs are classified into 5 categories or schedules based on the drug's acceptable medical use and the drug's misuse potential. The lower the schedule number, the higher the potential for abuse. The DEA classifies drugs in the following way. Schedule 1 drugs carry a high potential for abuse and have no acceptable medical use. Examples are heroin and LSD. Schedule 2 drugs have a high potential for abuse, are considered dangerous, and are available only by prescription. Examples include methadone, Demerol, and Ritalin. Schedule 3 drugs have a low to moderate potential for misuse and are available only by prescription. Examples are testosterone, Tylenol, and Suboxone. Schedule 4 drugs are low-risk drugs and are available by prescription. Examples of Schedule 4 drugs are Xanax, Ativan, and Darvocet. I should have said Tylenol with codeine for Schedule 3, not just Tylenol. Schedule 3, Tylenol with codeine. Schedule 5 drugs contain limited quantities of certain narcotics for the treatment of diarrhea, coughing, and pain. Examples are atropine diphenoxylate, or Lamotil, Robitussin, Lyrica, are all available over the counter. Then we have a big table here, table 22.1, commonly abused drugs. It's a big table, I'm not going to read it all. Okay, comorbidity. Comorbidity refers to 2 or more disorders occurring in the same person at the same time with potential interactions and exacerbation symptoms. Co-occurring disorders may include any combination of 2 or more substance use disorders and mental disorders identified in the DSM-5. In 2014, 20.2 million adults, 8.4%, had a substance use disorder. Of these, 7.9 million people had a co-occurring disorder. Major depressive disorders, bipolar disorder, and anxiety disorders are twice as likely as unaffected individuals to have a substance use disorder. Antisocial personality disorder and conduct disorder are commonly associated with substance abuse. Risk factors: biological, genetic. Alcohol use disorder runs in families, and about 40 to 60% of the risk comes from inheritance. Monozygotic identical twins are more likely to share alcohol use problems than are fraternal twins. Identical male twins are more likely to share alcohol use disorder than are female twins. Up to 4-fold increase in risk occurs in children of affected individuals, even when the children are given up for adoption or raised in other homes. There is some evidence to suggest that some genes may reduce the risk of alcohol consumption by impacting alcohol metabolism. For example, certain alleles of the alcohol dehydrogenase and aldehyde dehydrogenase genes can cause a buildup of acetaldehyde that creates the classic flushing response. There appears to be genetic underlying vulnerability to addiction that expresses itself in a variety of substances. SUDs, such as cannabis, cocaine, and opiates, definitely run in families. Twin studies support heritability in SUDs. Estimates range from 30% to 40% for hallucinogens and stimulants, and as high as 70 to 80% for cocaine and opiates. Neurochemical. Researchers have found neurotransmitters for all the SUDs with the exception of alcohol. The opioids, for example, act on opioid receptors. People with too little natural opioid activity or too much opioid antagonism might be prone to medicating through the use of opioid drugs. Even people who originally had normal opioid function will develop altered function with the repeated use of external opioids, to the point where taking the drug makes them feel normal again. The major neurotransmitters involved in developing substance use disorders are the opioid, ketylcholine, especially dopamine, and gamma aminobutyric acid, GABA, systems. The dopaminergic neurons in the ventral tegmental area, VTA, are especially important in the sensation of reward. Here we have a nice little graphic of the reward pathway in the brain, neurobiology of addiction, description of the action of Narcan, and also a description of brain dysfunction, tolerance, addiction, and Narcan's reversal of heroin overdose. That's about half a page. Environmental factors. Many chronic stressors have their roots in socioeconomic factors. Poverty raises the risk of an unfavorable living environment, lack of parental supervision, poor educational resources, and impaired support systems. A cycle of negative environmental events often begins within disadvantaged neighborhoods, increasing stress and anxiety, along with a lack of or negative social ties, which contributes to depression. Coping mechanisms may include drugs and acting out behaviors, leading to destructive consequences and interaction with the legal system. Adolescents may be strongly influenced by their peers to engage in substance abuse. Alcohol, which has been referred to as a social lubricant, may increase an adolescent's feeling of belonging. Using alcohol, tobacco, and marijuana at an early age is strongly associated with coming from a home with low parental supervision. Sociocultural. Substance abuse may create a sense of community and belonging in otherwise isolated individuals. The lifestyle of substance abusers may even seem alluring and dramatic to vulnerable people. In some cultures and religions, alcohol use is not accepted, and any use would be considered deviant. In other cultures, alcohol use is a regular part of everyday life, and the amount of consumption would be alarming to people outside the culture. Muslim-majority countries such as Pakistan, Libya, and Saudi Arabia have prohibitions against alcohol. In Afghanistan, it is illegal for citizens to purchase alcohol, but there are still places for foreigners to drink. In the United States, some Christian denominations such as Pentecostal, Baptist, and Mormon reject the use of alcohol. Clinical picture. Caffeine. Caffeine is the most widely used psychoactive substance in the world. I'm drinking some right now. According to the APA, unlike the other substances discussed in this chapter, excessive caffeine use is not an official use disorder. However, caffeine can result in intoxication and withdrawal. The half-life of caffeine in the human body is 3 to 10 hours, and the peak concentration for most people is 30 to 60 minutes. Caffeine intoxication. The prevalence of caffeine intoxication in the United States is about 7%. Caffeine intoxication is characterized by behavioral symptoms such as restlessness, nervousness, excitement, agitation, rambling speech, and inexhaustibility. Physical symptoms of intoxication are flushed face, diuresis, GI disturbance, muscle twitching, tachycardia, and cardiac arrhythmia. These symptoms are distressing to the individual and result in impairment of normal areas of functioning. Individuals with tolerance may not experience these symptoms. Extremely high doses may result in grand mal seizures, and respiratory failure may cause death. Excessive use is associated with many psychiatric problems, including bipolar disorders, eating disorders, and sleep disorders. Caffeine withdrawal is not associated with medical problems or the need for intervention. Removal of caffeine from the daily routine results in headache, drowsiness, irritability, or concentration. Some people experience flu-like symptoms such as nausea, vomiting, and muscle aches. Symptoms occur within 12 to 24 hours after the last dose, peak in 24 to 48 hours, and resolve within 1 week. Cannabis use disorder. Cannabis or marijuana is the most widely used, often illegal drug in the world and the fourth most commonly used psychoactive drug in the United States after caffeine, alcohol, and nicotine. It comes from the dried leaves, flowers, stems, and seeds from the hemp plant Cannabis sativa, a chemical of delta-9 tetrahydrocannabinol is responsible for its mind-altering effects. The concentrated form of cannabis is known as hashish. Synthetic cannabinoids of THC, dronabinol or marinol, and nabilone or sesamet are available by prescription for the nausea and vomiting associated with chemotherapy for cancer. The 12-month prevalence of cannabis use disorder in adolescents is about 3.5% and about 1.5% in adults. Males are more likely to have this disorder, which tends to progress slowly. Symptoms include using larger amounts over a long period of time, craving, tolerance, and withdrawal. Individuals with heavy marijuana use patterns may try to quit, cut down, or control its use. Too much time is spent getting cannabis, using it, and recovering from its effects. The use of the substance results in problems with work, home life, education, social, physical well-being. Cannabis intoxication heightens users' sensations. They experience brighter colors, see new detail in common stimuli, and time seems to go more slowly. In higher doses, they experience depersonalization and derealization. Motor skills are impacted for 8 to 12 hours, and driving and the use of machinery may be hazardous. Delirium results in marked impairment in cognition and performance. Physical symptoms of intoxication include red eyes from vessel dilation or conjunctival injection, increased appetite, dry mouth, and tachycardia. Withdrawal from cannabis is comparatively late, within 1 week of cessation. Symptoms include irritability, anger, aggression, anxiety, restlessness, and depressed mood. Because people often use marijuana as a sleep aid, insomnia and disturbing dreams may ensue without it. A decreased appetite may lead to weight loss. Physical symptoms of marijuana withdrawal include at least one of the following: abdominal pain, shakiness, sweating, fever, chills, or headache. Treatment. Drug screens can detect cannabis for up to 4 weeks after use. Abstinence and support are the main principles of treatment for cannabis use disorder. Hospitalization or outpatient care may be required. Individual, family, and group therapies can provide support. Anti-anxiety medication may be useful for short-term relief of withdrawal symptoms. Patients with underlying anxiety and depression may respond to antidepressant therapy. Hallucinogen Use Disorder. The use of hallucinogens has no medical use. A definition: they are intoxicants. Cause a profound disturbance in reality. Hallucinogens are associated with flashbacks, panic attacks, psychosis, delirium, and mood and anxiety disorders. They are both natural and synthetic substances. Hallucinogens are classified as Schedule I controlled substances, meaning they have no medical use and carry a high abuse potential. Hallucinogens are found in some plants and mushrooms, or they can be man-made. They are commonly divided into 2 broad categories: classic hallucinogens, such as LSD, and dissociative drugs, such as PCP and ketamine. The APA identifies 2 use disorders related to hallucinogens: PCP and other hallucinogens. Both problems cause a clinically significant impairment or distress within a 12-month period, including craving, difficulty with role obligations, impairment, and tolerance. Intoxication is characterized by clinically significant psychological and behavioral changes. Paranoia, impaired judgment, intensification of perceptions, depersonalization, and derealization are commonly experienced while using hallucinogens. Illusions, hallucinations, and synesthesias, i.e. hearing colors or seeing sounds, are particularly prominent with this type of intoxication. Physical symptoms include pupillary dilation, tachycardia, sweating, palpitations, blurred vision, tremors, and incoordination. Treatment for hallucinogen intoxication includes talking the patient down. This refers to reassurance that the symptoms are caused by the drug, and the symptoms will subside. In severe cases, an antipsychotic, such as Haldol, or a benzo, such as Valium, can be used in the short term. PCP intoxication is a medical emergency that can result in dangerous and violent side effects. People under the influence of this drug can be belligerent, assaultive, impulsive, and unpredictable. Significant physical manifestations of this drug include nystagmus or involuntary eye movements, hypertension, tachycardia, diminished response to pain, ataxia, loss of voluntary muscle control, dysarthria, unclear speech, muscle rigidity, seizures, coma, and hyperacusis, which is sensitivity to sound. Hyperthermia and seizure activity may also occur. Management of individuals intoxicated by PCP is primarily supportive. Patients who have ingested PCP cannot be talked down and may require restraint and a calming medication such as a benzo. Mechanical cooling may be necessary for severe hyperthermia. There is no official withdrawal diagnosis or pattern with prolonged hallucinogen use. However, hallucinogen persisting perception disorder may be experienced during periods of sobriety, particularly from LSD. The prevalence of this problem among users is about 4%. The hallmark of this problem is the re-experiencing of perceptual symptoms that were experienced while intoxicated. These symptoms are distressing and impair the individual from normal functioning for weeks, months, or even years. Inhalant Use Disorder. Volatile hydrocarbons are toxic gases inhaled through the nose or mouth to enter the bloodstream. Common household products and chemicals that share similar pharmacological properties includes solvents from glues and adhesives, propellants found in aerosol, paint sprays, hairsprays, and shaving cream, thinners such as paint products and correction fluids, fuels such as gasoline and propane. Those who use inhalants usually use them only for a short period of time. Some users continue their use despite knowing that this practice is causing serious problems. Characteristics of out-of-control inhalant use are using more and more, craving intolerance, craving intolerance. Wrong inflection there. Inhalants cause failure in major life roles and problems in interpersonal relationships. Sudden sniffing death from cardiac arrhythmias may occur with inhalants, particularly with butane and propane. This disorder occurs primarily between the ages of 12 to 17 years, with a 12-month prevalence rate of about 0.4%. That's sad. Small doses of inhalant result in disinhibition and euphoria. High doses can cause fearlessness, illusions, auditory and visual hallucinations, and a distorted body image. Apathy, diminished social and occupational functioning, impaired judgment, and impulsive and aggressive behavior accompany intoxication. Physical responses of inhalant intoxication include nausea, anorexia, nystagmus, depressed reflexes, and diplopia. That's double vision. Where was I? High doses and long exposures can lead to stupor, unconsciousness, and amnesia. Delirium, dementia, and psychosis are also serious possibilities from inhalant use. Although withdrawal is not considered a disorder in the DSM-5, some users develop a withdrawal syndrome when ceasing inhalant use. Treatment. Inhalant intoxication usually does not require any treatment. Serious and potentially fatal responses such as coma, cardiac arrhythmias, or bronchospasm do happen. Psychotic response can be induced by inhalant intoxication. This self-limiting, few hours to a few weeks, problem may require careful use of Haldol to manage severe agitation. Little box here. Culture of teenager inhalant use. During a 15-year period, teens in the United States abused more than 3,400 different products by inhalation, also known as huffing. Butane, propane, and air fresheners had the highest fatality rate. The peak age for inhalant abuse is 14 years old. Inhalant use results in life-threatening symptoms, permanently disabling illnesses, and death. Adolescent use of inhalants is also associated with more sexually transmitted infections in adulthood, particularly among black men. That seems random. The most commonly abused substances are propellants, especially aerosol dusters, followed by gasoline and paint. Other products that are commonly inhaled are hairspray, spray deodorant, glue, correction fluid, and carburetor cleaner. There's a little table here, 22.2, trends in prevalence of heroin use, time period and age ranges. And now we get into opioid use disorder. Opioid misuse, particularly with heroin and prescription drugs, is a chronic relapsing disorder. In opioid use disorders, cravings result in larger amounts and longer periods of time being devoted to the drug and increasing tolerance to its effects. The use of this substance results in significant impairment in life roles, interpersonal conflict, and puts a person in physically hazardous situations. The ratio of affected males to females is 1.5 to 5. In 2014, about 435,000 people aged 12 or older were current heroin users. This number corresponds to about 0.2% of the population. Opioid use problems usually begin in late teens or early 20s. Increasing age is associated with fewer affected individuals, probably due to early mortality and a cessation of use after age 40. Table 22.2 identifies the prevalence of heroin use among various age groups. Intoxication. People intoxicated on opioids exhibit psychomotor retardation, drowsiness, slurred speech, altered mood, and impaired memory and attention. They also exhibit pupillary constriction. Intense drowsiness can lead to a coma. Withdrawal symptoms for opioids occur after a cessation of or reduction in heavy opioid use, or after an opioid antagonist has been administered. Symptoms of withdrawal include mood dysphoria, nausea, vomiting, diarrhea, muscle aches, fever, and insomnia. Other classic symptoms of withdrawal are lacrimation, watery eyes, rhinorrhea, runny nose, pupillary dilation, and yawning. The symptom of piloerection, or bristling of hairs, or goose flesh, is the origin of the term cold turkey for the abstinence syndrome. Males may experience sweating and spontaneous ejaculations while awake. Whoa. Morphine, heroin, and methadone withdrawal syndrome begins 6 to 8 hours after the last dose, following a period of at least a week of use. It reaches intensity during the second or third day and then subsides during the next week. Demerol withdrawal begins within 8 to 12 hours from abstinence and lasts about 5 days. See box 22.1 for some of the signs and symptoms of intoxication and withdrawal. We got intoxication, bradycardia, hypotension, hypothermia, sedation, pinpoint pupils, hypokinesis or slowed movement, slurred speech, head nodding, euphoria, pain-killing effects, and calmness. Withdrawal symptoms are tachycardia, hypertension, hyperthermia. Enlarged pupils are mydriasis, hyperreflexia, which is abnormally heightened reflexes, diaphoresis, piloerection, increased respiratory rate, tearing and yawning, runny nose, muscle spasms, abdominal cramps, nausea, vomiting, diarrhea, bone and muscle pain, and anxiety. Yeehaw. Overdose. Death attributable to opioids usually stems from respiratory arrest due to the respiratory depressant effect of the drug. Symptoms of overdose include unresponsiveness, slow respiration, coma, hypothermia, hypotension, and bradycardia. 3 symptoms, coma, pinpoint pupils, and respiratory depression, are strongly suggestive of overdose. Overdose treatment. Treatment for an overdose begins with promoting breathing by aspirating secretions and inserting an airway. Mechanical ventilation should be used until Narcan, a specific opioid antagonist, can be given intramuscularly, subcutaneously, or intravenously. You can give it up the nose too. Increased respirations and pupillary dilation should happen quickly. Too much Narcan or naloxone may produce withdrawal symptoms. Duration of action for naloxone is short compared with many opioids, so repeated administration may be required. General treatment, individual therapy, behavioral therapy, cognitive behavioral therapy, family therapy, and social skills training may all be helpful in the management of opiate use disorder. Support groups such as Narcotics Anonymous, a 12-step program, are excellent sources of help. More structures provided in residential treatment and therapeutic communities. They work best in cases of highly motivated individuals. Confrontation in the group environment and isolation from the outside world are emphasized in these settings. Methadone, Dolafine, or Methadose is a synthetic narcotic opioid. It is used to decrease the painful symptoms of opiate withdrawal. It also blocks the euphoric effect of opiate drugs, such as heroin, morphine, and codeine, as well as semi-synthetic like oxycodone and hydrocodone. Methadone can only be dispensed through an opiate treatment program certified by SAMHSA. Once-a-day dosing is adequate. Methadone, too, will eventually need to be withdrawn due to dependence. For pregnant users, a low dose of methadone may be the safest course. Neonatal withdrawal is usually mild and can be managed with paregoric, whatever that is. Some serious side effects may occur while taking methadone. Patients should be instructed to seek medical care if they experience difficulty breathing or shallow breathing, feel lightheaded or faint, or experience chest pain or a fast or pounding heartbeat. Hives, rash, or swelling of the face, lips, tongue, or throat could also be serious symptoms. Hallucinations or confusion should be reported to the care provider. Buprenorphine is used to help people reduce or quit their use of heroin or other opiates such as pain relievers like morphine. Buprenorphine is an opioid partial agonist. Like opiates, it produces effects such as euphoria or respiratory depression, but these effects are weaker than those of full drugs such as heroin and methadone. The FDA has approved the following Schedule III buprenorphine products, some of which contain Narcan. Subutex, Subutex sublingual tablets, Bunavil buccal film, Zubsolv sublingual tablets. Probuphine is supplied by 4 1-inch rods surgically implanted under the skin of the upper arm for 6 months. Side effects of buprenorphine include nausea, vomiting, constipation, muscle aches and cramps, insomnia, irritability, and fever. This drug is used only after abstaining from opiates for 12 to 24 hours and in the early stages of opiate withdrawal. It can bring an acute withdrawal for patients not in the early stages of withdrawal and who have other opiates in their bloodstream. Because it's a long-acting drug, once patients have been stabilized, they can sometimes switch to alternate day dosing instead of dosing every day. Now, Trexone or Vivitrol is an opioid antagonist indicated for the prevention of relapse to opioid dependence following detoxification. A long-acting injectable version of this drug, Revia, is given once a month. If a person using naltrexone relapses and uses the misused drugs, naltrexone blocks the euphoric and sedative effects. Side effects include weakness, tiredness, insomnia, increased thirst, anxiety, nervousness, restlessness, irritability, lightheadedness, fainting, muscle or joint aches, decreased sex drive, impotence, or difficulty having an orgasm. Sounds horrible. Okay, Got a little box here, evidence-based practice. Early use of non-medical prescription opioids linked to subsequent heroin use. The national epidemic of heroin use and its extremely dangerous consequence of overdose, researchers are trying to pinpoint which groups may be at most risk. 1, to explore the relationship between non-medical use of prescription opiates in childhood and subsequent heroin use in young adults. And 2, to determine whether age, race, ethnicity, or income played a role in increasing risk. This is boring. I'm not going to read the rest of it. Okay, sedative, hypnotic, and anti-anxiety medication use disorder. Drugs in this category include the benzos, benzo-like drugs such as zolpidem and zaleplon, carbamates, barbiturates, and barbiturate-like hypnotics like methaqualone. This class includes all prescription sleeping medications and almost all prescription anti-anxiety drugs. Craving is a typical feature. Use of these brain depressants negatively affects role performance and relationships. Significant tolerance and withdrawal can develop in anyone using these drugs, even for their intended indication. A use disorder diagnosis is only given in the presence of additional DSM-5 criteria, such as clinically significant maladaptive behavior or psychological changes. The 12-month prevalence of this problem is about 0.2% in adults. It occurs in males slightly more often than in females. Sedative, hypnotic, and anti-anxiety medication use disorders are highest among 18 to 29-year-olds, 0.5%, and lowest among individuals 65 and older, 0.04%. As a group of depressants, the criteria for intoxication makes sense. Slurred speech, incoordination, unsteady gait, nystagmus, and impaired thinking. Coma is a dangerous possibility with this class of drugs. Inappropriate aggression and sexual behavior, mood fluctuation, and impaired judgment may also be side effects. Overdose treatment. Overdose treatment includes gastric lavage, pump in the stomach, activated charcoal, and careful vital sign monitoring. Patients who are awake after overdosing should be kept awake to prevent a loss of consciousness. If unconscious, an intravenous fluid line should be established. An endotracheal tube may be required to provide a patent airway, and mechanical ventilation can be used if necessary. Withdrawal. Repeated depressing of the central nervous system, along with the body's daily attempt to return to homeostasis, results in rebound hyperactivity with the removal of the substance. Hence, we see symptoms such as autonomic hyperactivity, tremor, insomnia, psychomotor agitation. Okay, let me chill out. Psychomotor agitation, anxiety, and grand mal seizures. The degree and timing of the withdrawal syndrome depends on the specific substance. Half-life is an important predictor of time. Treatment for withdrawal, a gradual reduction of benzos will prevent seizures and other withdrawal symptoms. Barbiturate withdrawal can be aided by using a long-acting barbiturate such as phenobarbital. Stimulant use disorder. Amphetamine-type, cocaine, or other stimulant drugs, second only to cannabis, is the most widely used illicit substances in the United States. They typically produce a euphoric feeling and high energy. Long-distance truckers, students studying for exams, soldiers in wartime, and athletes in competition use these drugs. As with all use disorders, increased use, craving, and tolerance are accompanied by reduced ability to function in major roles. Stimulants represent a significant problem, and the use disorder pattern can occur in as little as 1 week. The estimated 12-month prevalence for amphetamine-type stimulants is about 0.2% in adults. Both genders are affected equally. Intravenous stimulant use is greater in males, around 4 to 1. Cocaine use disorder is higher, 0.3%, more male users. Stimulant intoxication. People feel superhuman while using stimulants. They feel elated, euphoric, and sociable. Unfortunately, they're also hypervigilant, sensitive, anxious, tense, and angry. Physical symptoms include 2 or more of the following: chest pain, cardiac arrhythmias, high or low blood pressure, tachycardia, bradycardia, respiratory depression, dilated pupils, perspiration, chills, nausea or vomiting, weight loss, psychomotor agitation or retardation, weakness, confusion, seizures, or coma. Withdrawal symptoms begin within a few hours to several days. Symptoms include tiredness, vivid nightmares, increased appetite, insomnia or hypersomnia, and psychomotor retardation or agitation. Functionality is impaired during the withdrawal process. Depression and suicide thoughts are the most serious side effects of stimulant withdrawal. See box 22.2 for some of the signs and symptoms of intoxication and withdrawal. Box 22.2. Stimulant intoxication, short term. Decreased energy, decreased appetite, mental alertness, increased heart rate / pressure, dilated pupils. Long term, irregular heartbeat, chest pains, increased risk of heart attack, panic attacks, depression, delusions, hallucinations, cocaine bugs. And withdrawal symptoms are depression, hypersomnia or insomnia, fatigue, anxiety, irritability, poor concentration, psychomotor retardation, increased appetite, paranoia, and drug craving. Withdrawal treatment for amphetamines in inpatient setting is usually necessary. Individual, family, and group therapy are helpful. Depending upon the amphetamine used, specific drugs may be used short-term. Antipsychotics may be prescribed for a few days. If there is no psychosis, Valium is useful in treating agitation and hyperactivity. Once the patient has been withdrawn from the amphetamine, depression can be treated in antidepressants such as Wellbutrin. The 1 to 2 week cocaine withdrawal period is distinct because there are no physiological disturbances that require inpatient care. Outpatient settings may be tried as a first approach. Some patients experience fatigue, mood changes, disturbed sleep, craving, and depression. There are no drugs that reliably reduce the intensity of these symptoms. The intense craving associated with cocaine withdrawal may require hospitalization to remove the affected individual from the usual social settings and drug sources. Unscheduled urine drug testing is usually warranted. Alright, we're almost there. 10 more pages. Tobacco use disorder. Craving, persistent, and recurrent use, and tolerance are all symptoms of tobacco use disorder. Dependence happens quickly. Cigarettes are the most commonly used tobacco product. 12-month prevalence of tobacco use disorder is about 13% in adults. Rates are slightly higher in males as compared with females. Most people who use tobacco begin before the age of 18. Tobacco withdrawal is distressing. At least 4 of the following symptoms occur: irritability, anxiety, depression, difficulty concentrating, restlessness, and insomnia. Within days after smoking cessation, heart rates decrease by 5 to 12 beats per minute. Within the first year after smoking cessation, people increase their weight by an average of 4 to 7 pounds. Behavioral therapy is useful to teach the patient to recognize cravings and respond to them appropriately. Hypnosis has been used successfully to treat tobacco withdrawal. Nicotine replacement therapies in the form of gum, lozenges, nasal sprays, and patches are highly successful treatments. Non-nicotine therapy options include antidepressant Zyban, which reduces cravings for nicotine. Clonidine catapress decreases sympathetic activity and reduces withdrawal symptoms. Chantix provides some nicotine effects to ease withdrawal symptoms and blocks the effects of nicotine from cigarettes if smoking is resumed. Gambling disorder. Gambling is a compulsive activity that causes economic problems, significant disturbances in personal, social, or occupational functioning. Individuals with this disorder are preoccupied with the behavior, experience an increasing desire to gamble, and lie to conceal the extent of the problem. They may try to control the behavior, cut back, or stop gambling. Otherwise, honest people may commit illegal acts to finance their addiction. They may rely on others to help pay off debts and gamble to recoup losses. The 1-year prevalence rate in females is about 0.2%, and for males it is 0.6%. The lifetime prevalence of gambling disorder is about 0.4 to 1%. Early expression of gambling disorder is more common among males, although the progression is more rapid for females. This problem usually develops over the course of years. Gambling may be regular or episodic. Heavy gambling may be interspersed with abstinence. Stress and depression may increase the behavior. Treatment. Legal problems, pressure from family, and other psychiatric problems may bring the person who gambles excessively into treatment. Gamblers Anonymous, GA, is a 12-step program modeled on Alcoholics Anonymous. It involves public confession, peer pressure, and peer counselors who are reformed gamblers. Hospitalization may help by removing patients from gambling environments Individual, group, and family therapy are useful in supporting the patient. Medications such as SSRIs, Wellbutrin, mood stablers such as lithium, and anticonvulsants such as Topamax may be helpful. Second-gen antipsychotics have also been used in the treatment of gambling disorders. Naltrexone, an opioid antagonist, may be given to individuals with the most severe symptoms of the disorder. All right, alcohol use disorder. Although alcohol is a sedative, it creates an initial feeling of euphoria. This is probably related to decreased inhibitions. A cluster of behavioral and physical symptoms characterizes alcohol use disorder. The full criteria for alcohol use disorder are listed in the DSM-5 box, and I'm going to read it. Here we go. DSM-5 criteria for alcohol use disorder. A problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. 1. Alcohol is often taken in larger amounts or over a longer period of time than was intended. 2. There is a persistent desire or unsuccessful efforts to cut down or control alcohol use. 3. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. 4. Craving or a strong desire to urge to use alcohol. 5. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. 6. Continued alcohol use despite having persistent or recurring social or interpersonal problems caused or exacerbated by the effects of alcohol. 7. Important social, occupational, or recreation activities are given up or reduced because of alcohol use. 8. Recurring alcohol use in situations in which it is physically hazardous. 9. Alcohol use continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. 10. Tolerance, as defined by either of the following. A need for markedly increased amounts of alcohol to achieve intoxication or desired effect. B, a markedly diminished effect with continued use of the same amount of alcohol. 11. Withdrawal, as manifested by either of the following. C, the characteristic withdrawal syndrome for alcohol. D, alcohol, or a closely related substance, such as a benzodiazepine, is taken to relieve or avoid withdrawal problems. Specify if, in early remission, after full criteria for alcohol use disorder were previously met, none of the criteria for alcohol use disorder have been met for at least 3 months, but for less than 12 months, with the exception criteria A4 may be met. What is A4? Craving or strong desire or urge to use alcohol. Alright. In sustained remission, after full criteria for alcohol use disorder were previously met, none of the criteria for alcohol use disorder have been met at any time during a period of 12 months or longer, with the exception that criterion A4 may be met. Sounds like I just read the same thing twice, but whatever. Specify if, in a controlled environment, this additional specifier is used if the individual is in an environment where access to alcohol is restricted. Wowzers. Alright. Severity is based on the number of symptoms, mild, 2 to 3 symptoms, moderate, 4 or 5 symptoms, and severe, presence of 6 or more symptoms. That's pertaining to the box I just read. Types of problematic drinking. Amounts of alcohol that are considered safe vary depending upon individual factors. Table 22.3 identifies the numbers of drinks that are considered acceptable depending on gender, age, and pregnancy. And that's here on the same page. I won't read it. Excessive drinking is described by 2 different terms. Binge drinking refers to drinking too much alcohol quickly. For women, this amount is 4 or more drinks within 2 hours. For men, this amount is 5 or more drinks within 2 hours. Heavy drinking is characterized by drinking too much too often. 8 or more drinks in a week constitutes heavy drinking in women. Men who drink more than 14 drinks in a week are considered heavy drinkers. Alcohol intoxication. The legal definition of intoxication in most states requires a blood concentration of 80 or 100 milligrams ethanol per deciliter of blood. This concentration may also be expressed as 0.08 to 0.1 grams per deciliter. Okay. Signs and symptoms of alcohol intoxication based on blood alcohol are 0.02. 2 alcoholic drinks, slower motor performance, decreased thinking ability, altered mood, and reduced ability to multitask. 0.05. 3 alcoholic drinks, impaired judgment, exaggerated behavior, euphoria, and lower alertness. 0.08. 4 alcoholic drinks, poor muscle coordination, altered speech and hearing, difficulty detecting danger, impaired judgment, poor self-control, and decreased reasoning. 0.1. 5 alcoholic drinks, slurred speech, poor coordination, and slow thinking. 0.15. 6 alcoholic drinks, vomiting, unless high tolerance, and major loss of balance. 0.2. 8 to 10 alcoholic drinks, memory blackouts, nausea, and vomiting. 0.3. More than 10 alcoholic drinks, reduction of body temperature, blood pressure, respiratory rate, sleepiness, and amnesia. 0.4. Impaired vital signs and possible death. Intoxication is based on a number of factors, including how quickly alcohol is consumed. Quicker ingestion results in higher levels of BAC. In the United States, a standard drink is one that contains about 14 grams of pure alcohol. This amount is found in 12 ounces of beer with 5% alcohol content, 5 ounces of wine, 12% alcohol content, and 1.5 ounces of distilled spirits with 40% alcohol content. Alcohol withdrawal. Withdrawal occurs after reducing or quitting alcohol after heavy and prolonged use. The classic sign of alcohol withdrawal is tremulousness, commonly called the shakes or the jitters, that begins 6 to 8 hours after cessation. Mild to moderate alcohol withdrawals includes agitation, lack of appetite, nausea, vomiting, insomnia, impaired cognition, and mild perceptual changes. Both systolic and diastolic blood pressures increases, as does pulse and body temperature. Librium is useful for tremulousness and mild to moderate agitation. Psychotic and perceptual symptoms may begin in 8 to 10 hours. If your patient is undergoing withdrawal to the point of psychosis, it should be considered a medical emergency because of the risks of unconsciousness, seizures, and delirium. The benzos, Ativan, and Librium can be given either orally or intramuscularly and tapered over the following 5 to 7 days. Withdrawal seizures may occur within 12 to 24 hours after alcohol cessation. These seizures are generalized and tonic-clonic. Additional seizures may occur within hours of the first seizure. Valium, given intravenously, is a common treatment for withdrawal seizures. Alcohol withdrawal delirium, also known as delirium tremens, is a medical emergency that can result in death in 20% of untreated patients, usually as a result of medical problems such as pneumonia, renal disease, hepatic insufficiencies, or heart failure. Alcohol withdrawal delirium may happen any time in the first 72 hours. Autonomic hyperactivity may result in tachycardia, diaphoresis, fever, anxiety, insomnia, and hypertension. Delusions and visual tactile hallucinations are common in alcohol withdrawal delirium. Delusions and hallucinations may result in unpredictable behaviors as patients try to protect themselves from what they believe are genuine dangers. Patients on any medical floor are at risk for this condition after cessation of heavy drinking for 3 days and are a danger to themselves and others. Serious physical illness such as hepatitis or pancreatitis may increase the likelihood of alcohol withdrawal delirium. It is rare to see this syndrome in individuals in good physical health. Prevention of alcohol withdrawal delirium is the goal. Oral Valium may be useful in the symptomatic relief of acute agitation, tremor, impending or acute delirium tremens, and hallucinations. Librium may keep your patient out of danger. However, once delirium appears, IV Ativan is used to treat these severe symptoms. Seclusion may be necessary. Dehydration, often exacerbated by diaphoresis and fever, can be corrected with oral or IV fluids. Alcohol-induced persisting amnestic disorder. Wernicke-Korsakoff syndrome. People with a heavy use of alcohol for many years may suffer from short-term memory disturbances. One memory-reducing problem is Wernicke's encephalopathy, an acute and reversible condition. Another problem is Korsakoff's syndrome, a chronic condition with a recovery rate of only about 20%. The pathophysiological connection between the two problems is a thiamine deficiency, which may be caused by poor nutrition associated with alcohol use or by the malabsorption of nutrients. Wernicke's encephalopathy is characterized by altered gait, vestibular dysfunction, confusion, and several ocular motility abnormalities, such as horizontal nystagmus, lateral orbital palsy, and gaze palsy. These eye-focused signs are bilateral, but not necessarily symmetrical. Sluggish reaction to light and anisocoria, unequal pupil size, are also symptoms. Wernicke's may clear up within a few weeks or may progress into Korsakoff syndrome, the more severe and chronic version of this problem. That's called having a wet brain. Wernicke's encephalopathy responds rapidly to large doses of IV thiamine 2 or 3 times daily for 1 to 2 weeks. Treatment of Korsakoff's is also thiamine for 3 to 12 months. Most patients with Korsakoff syndrome never fully recover, although cognitive improvement may occur with thiamine and nutritional support. Blackouts. An extremely disturbing aspect of alcohol use is blackouts. They're caused by excessive consumption of alcohol, followed by episodes of amnesia. During these periods of time, a person actively engages in behaviors, can perform complicated tasks, and appears normal. This phenomenon is due to alcohol's ability to block the consolidation of new memories into ones through the hippocampus and related temporal lobe structures. Fetal alcohol syndrome is the leading cause of intellectual disability in the United States. Alcohol during pregnancy inhibits intrauterine growth and postnatal development, resulting in microcephaly, craniofacial malformations, and limb and heart defects. As adults, affected individuals tend to have a short stature. Women with alcohol-related disorders have a 35% risk of having a child with defects. Figure 22.1 illustrates the facial features of alcohol fetal syndrome. There's a nice little picture there. Some distinctive features. Systemic effects. Peripheral neuropathy. This is just back to alcohol in general here. Chronic alcoholism leads to nutritional deficiencies, particularly thiamine, due to drinking rather than eating, leading to damage to the peripheral nervous system. The feeling of pins and needles in the lower extremities is a common symptom of this neuropathy. Other symptoms include numbness, muscle weakness, sensitivity to touch, and burning. Discontinuation of alcohol will prevent further deterioration. Alcoholic myopathy. Binge drinking may cause a sudden acute alcoholic myopathy with muscle weakness and myonecrosis or muscle damage. Chronic alcoholic myopathy develops gradually. The characteristic symptom of this problem is the significant reduction in muscle mass and resulting muscle weakness. Recovery is possible if alcohol is avoided, but the time to recovery varies from rapid, days to weeks, with the acute form to lengthy, weeks to months, with the chronic form. Alcoholic cardiomyopathy. Direct toxic effects of alcohol can weaken and thin the muscles of the heart, leading to enlargement and eventual heart failure. Symptoms of alcoholic cardiomyopathy are similar to other types of heart failure, including fatigue, shortness of breath, and edema of the legs and feet. Esophagitis. Inflammation of the esophagus is a direct result of the toxic effects of alcohol on the esophageal mucosa. The vomiting related to alcohol overuse is also contributory to this condition. Esophageal varices are distended veins within the esophagus or the upper part of the stomach that result from heavy drinking. These veins are at risk for bursting, which results in a medical emergency. Gastritis. As a toxin, alcohol irritates and erodes the mucosal stomach lining. Symptoms of gastritis include nausea, vomiting, loss of appetite, belching, and bloating. Damage to the stomach lining may lead to ulcers or bleeding. Pancreatitis. Prolonged and hazardous drinking may result in pancreatic damage. Excessive drinking, usually more than 5 years, may result in an acute attack of pancreatitis. Continued alcohol misuse eventually results in chronic pancreatitis in a minority of misusers. Abdominal pain, nausea, and vomiting are the major symptoms of acute pancreatitis. Withdrawal of alcohol in the early stages will reverse the condition. The chronic condition results in malnutrition, weight loss, and diabetes mellitus. Withdrawal of alcohol in the chronic condition may reduce inflammatory episodes and allow for better control of diabetes. Alcoholic hepatitis. Alcohol gets processed by the liver and produces highly toxic chemicals. Excessive alcohol over an extended period of time may result in a diseased and inflamed liver. Alcoholic hepatitis only occurs in a minority of heavy users. Genetic factors such as how the body processes alcohol, other liver disorders such as hepatitis C, malnutrition, and being female increases the risk of this disorder. Symptoms of alcoholic hepatitis include appetite changes, dry mouth, weight loss, nausea and vomiting, pain or swelling of the abdomen, jaundice, fever, confusion, and fatigue. Cirrhosis of the liver. Cirrhosis is a slowly progressing disease in which healthy liver tissue is replaced by scar tissue. Eventually, the liver can no longer function properly because the scar tissue blocks the flow of blood through the liver. This slows the processing of nutrients, hormones, drugs, and naturally produced toxins. Cirrhosis is the 12th leading cause of death, of disease. Symptoms of cirrhosis of the liver include easy bleeding and bruising, pruritus, jaundice, ascites, leg edema, weight loss, confusion, spider-like blood vessels on the skin, otherwise known as petechiae, and testicular atrophy. Ugh. No treatment will cure cirrhosis or repair scarring. Liver transplantation may be necessary. Low-salt diets will reduce ascites. Leukopenia. When there is liver damage, alcoholism may cause low white blood cells due to vitamin deficiencies and low protein intake. Low white blood cells predispose individuals to infection and disease. Symptoms of leukopenia include periodontitis and gingivitis, fatigue, weakness, fever, and abdominal pain. Improved nutrition and alcohol cessation are indicated for this condition. Thrombocytopenia is a complication of liver cirrhosis characterized by a low platelet count. This is caused by platelet pooling in a large spleen and decreased thromboprotein production in the liver. Symptoms of thrombocytopenia include excessive bruising, otherwise known as purpura, petechiae, particularly on the lower legs, and prolonged bleeding from cuts. Platelet counts begin to rise within 2 to 5 days of abstaining from alcohol. And cancer. Alcohol consumption is a major risk factor for head and neck cancers, especially in the oral cavity, pharynx, and larynx. Alcohol use is associated with liver, breast, and colorectal cancers. Application of the nursing process. Screening. Alcohol is a major contributing factor in increased mortality and deaths, morbidity and disease, harm to others and injury, increased economic loss and disabilities. Alcohol can be fatal as a result of its severe withdrawal symptoms. Screening is essential to intervene early and provide treatment for people with substance use disorders and for those at risk of developing these disorders. The screening, brief intervention, and referral to treatment, SBIRT, is a comprehensive integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders as well as those who are at risk of developing these disorders. SBIRT identifies at-risk substance users for early intervention and consists of three major components. 1. Screening. A nurse or other healthcare professional in any healthcare setting assesses the severity of substance abuse and identifies the appropriate level of treatment. 2. Brief intervention. A nurse or other healthcare professional focuses on increasing insight and awareness regarding substance use and motivation towards behavioral change. And 3. Referral to treatment. A nurse or other healthcare professional provides those identified as needing more extensive treatment with access to specialty care. A variety of other screening tools are available to assist healthcare practitioners in gaining important information on which to base plans of care. Additional screening tools are Audit, the Alcohol Use Disorders Identification Test, CAGE, have you felt the need to C, cut down on your drinking? Are people A, annoyed by your drinking? Have you felt G, guilty about your drinking? Have you ever had a drink in the morning? E, eye-opener. That's CAGE. And then there's CAGE Aid. Questions are the same as CAGE but refers to adapted to include drugs. T, ACE, tolerance, annoyance, cut down, eye-opener. Those are the tools there. Formalized alcohol screening is as simple as using the Alcohol Use Disorders, the Audit Test developed for the World Health Organization. I'm sorry, this is some boring stuff. Audit has been effective for decades and continues to be used today. The clinician can administer this tool or the patient can self-report. Then we have a nice little big table here, 22.4, about audit. Takes up about half a page. During the screening process, instructions need to be clear and followed carefully. Non-judgmental attitudes help with objectivity, regardless of what the individual reveals. Several trends are important, such as the appearance of progression or loss of control, and whether or not tolerance or withdrawal is present. Once the screening process identifies a potential problem, a more complete assessment is warranted. Assessment. An alcohol use assessment is part of a more comprehensive assessment that evaluates the individual holistically. Ideally, this assessment involves an addictions professional with specialized knowledge and skills to make a diagnosis. The assessment will include a clinical examination of background pattern of substance abuse and any mental health symptoms. The nurse will make special note of any history of trauma, family history of substance abuse or mental health problems, and any disabilities, as well as an individual's strengths and level of willingness to change. As a result of this assessment, the individual may be identified as having a substance-related disorder. Family assessment. Understanding the process of addiction from a holistic perspective requires careful attention to the family. Living with an individual who misuses alcohol or other substances is a source of stress and requires family system adjustments. Codependence is a cluster of behaviors originally identified through research involving the family of alcoholic patients. People who are codependent often exhibit overly responsible behavior, doing for others what others could just as well do for themselves. People who are codependent often define their self-worth in terms of caring for others to the exclusion of their own needs. It's a big problem. Self-assessment. Alcohol use is self-inflicted. You should carefully assess personal thoughts, opinions, and feelings as the first step of remaining objective and establishing a therapeutic relationship with the person who misuses alcohol. Most of us have been impacted in some way by someone whose life has been torn apart by substance abuse. Recognizing and dealing with our responses by practicing introspection is essential to the provision of patient-centered care, protected from bias or counter-transference. You may be aware that registered nurses themselves might have personal substance abuse problems. No, never. For those nurses who become aware that they are engaging in risk-taking behaviors or that one of their colleagues may be experiencing difficulties, there are non-punitive alternatives to discipline programs in the form of peer assistance. Many state boards of nursing have developed an alternative to discipline programs to help impaired nurses. To determine if your state has this model, check with your state's Board of Nursing. Diagnosis. Once the comprehensive substance use assessment has been completed in a thorough, objective manner, the data are analyzed and potential or actual problems and needs are identified. Clinical decision-making skills will be used to determine which of the identified problems requires a priority intervention. Outcomes identification. The goals for treatment planning arise from the preferred outcome for each problem. Outcome measures may include immediate detox and stabilization for individuals experiencing withdrawal abstinence if individuals are actively drinking, motivation for treatment and engagement in early abstinence, and pursuit of recovery lifestyle for after discharge. Table 22.5 identifying signs and symptoms commonly experienced in substance abuse disorders, offering potential nursing diagnosis, and suggests outcomes. Planning. The treatment plan will be developed based on the assessment and diagnosis. For treatment to be successful, a patient-centered approach includes the patient's goals. The plan should take into account the patient's ability to recognize the problem and readiness or motivation to change. So yeah, nice big table on this page 22.5, signs and symptoms, nursing diagnosis, and outcomes for substance-related and addictive disorders. We can read that later. Implementation. Psychosocial interventions. Basic nursing interventions are useful in providing a supportive environment for managing substance use disorders. Promoting safety and sleep are essential first-line interventions. Also, patients with alcohol use disorder may have severely compromised nutritional status due to choosing substance over sustenance. Gradually reintroducing healthy food and hydration helps support body symptoms and neurological functioning. Support and encouragement for self-care will help improve self-esteem in individuals who may have long neglected themselves. The development of a therapeutic relationship sets the stage for exploring harmful thoughts, anxiety, hopelessness, and spiritual distress. An understanding of current coping skills along with identification of new skills provides tools to test in a safe setting. Assistance in goal setting helps a patient to see beyond the current situation and instills hope and direction. Psychobiological interventions. Pharmacological. With the completion of the Human Genome Project and ongoing genetic research, it is only a matter of time before the nurse's responsibility will include not only a review of laboratory data, but also a review of the patient's genetic profiles. That's going to suck. In addition to adding to the body of knowledge, this research will provide alternative options for treatment. Nurses administer medications and provide ongoing assessment of their efficacy and side effects after administration. Nurses need to monitor vital signs frequently since an increase in pulse, blood pressure, and body temperatures are clear signs of withdrawal. The goal is to keep the patient safe and comfortable and stay ahead of withdrawal so the patient does not suffer. Previously in the chapter we discussed medications used for other substances. Table 22.6 identifies medications used in the treatment of alcohol use disorder. I'm going to go straight there. We got Antabuse, we got Vivitrol, which is now Trexone, we got Camprol, which is acamprosate calcium, so relapse prevention. And then we got the benzos. We got the Ativan, Valium, Tegretol, anticonvulsant, barbiturate, phenobarbital, all that good stuff. Health teaching and health promotion. By 2020, substance use disorders and mental health disorders are predicted to surpass all physical diseases as the major causes of disability worldwide. So that was last year. If genetic vulnerability accounts for 40% to 60% of an individual's risk, prevention may be the best answer to the increasing problem of substance use and addiction. Health teaching is a part of the school curriculum, and schools may offer classes on understanding addiction as a brain disorder, its risk factors, and ways to prevent or limit exposure to psychoactive substances. Promoting classes for developing healthy coping and stress management skills and activities for increasing self-confidence and self-efficacy will also lower the risks for use of psychoactive substances. Social activities that increase supportive relationships, reduce the impact of stressful life events, provide a venue for community activities that provide health education and promotion. Pay special attention to understanding the particular impact of trauma as a risk factor. Physical, Sexual or emotional abuse at any age, physical trauma from accidents, natural disasters, or acts of violence or war can all be predisposing factors for the use of psychoactive substances or processes. Advanced practice interventions, psychotherapy. Advanced practice nurses and other substance use and addiction treatment professionals use a number of psychotherapies. CBT and motivational interviewing are commonly used evidence-based therapies. Destructive and negative thinking patterns play into the development of maladaptive behavioral patterns like substance use disorders. Cognitive behavioral therapy helps patients to explore thinking patterns so that the core belief system and any irrational core beliefs can be identified. Positive and negative consequences of alcohol use are explored. Patients learn to self-monitor their cravings and challenge these cravings realistically. Motivational interviewing is an approach based on the trans-theoretical or stages of change theory. It has gained popularity in its use as a brief, long-term, and supplementary intervention, particularly in the treatment of substance use disorders. It uses a person-centered approach to strengthen motivation for change. The advanced practice nurse, and patient usually meet for an hour at a time. Individuals may be at stage 1, pre-contemplation, and need assistance in admitting there is a problem. If they have acknowledged the problem, contemplation, they may still not be ready to commit to addressing it. The goal of treatment is to assist in the development of awareness and commitment. Preparation or getting ready and action or changing take place in early treatment phases. The maintenance stage is the ongoing commitment to the recovery program. Without continuing action, the individual will likely return to a previous behavior, relapse. Evaluation. Evaluation occurs on several levels, assessing the effectiveness of the treatment plan, using objective data to check whether nurse actions address patient's symptoms, and measuring the changes in the patient's behaviors for progress towards meeting stated goals. Problematic behaviors, patterns of expression, or perceptions may improve or only undergo changes in small increments, requiring alterations in the action steps or even the goals of the treatment plan to meet the patient's needs. During the treatment experience, conduct ongoing evaluation of the process to ensure that any transference or countertransference is managed, that the goals and outcomes of treatment remain patient-centered. Evaluation will also make it possible to ensure that the patient acquires the necessary skills and competencies for continued reflection and maintenance of the new lifestyle identification. There's a case study here, nice big table that we can read later. Okay, last page. The care continuum for substance use disorders. Continuity of care occurs through a continuum starting with detoxification, rehabilitation, halfway houses, partial programs, intensive outpatient and outpatient settings. Mutual support groups such as AA are strongly encouraged throughout the treatment process. Detox is warranted when the individual quits using a psychoactive substance known to cause withdrawal or when the individual is already in withdrawal. This is a medically managed inpatient program with 24-hour medical coverage while the patient's body clears itself of drugs. This process is accompanied by uncomfortable and even fatal side effects caused by withdrawal. Detox is also available as a medically monitored program with 24-hour professional supervision based on the severity of symptomology and the presence of comorbid conditions. Rehabilitation. Residential rehab programs are available as medically managed and medically monitored inpatient programs. The medically managed programs usually employ a 24-hour medical staff and provide intensive and specialized care for those individuals with either biomedical or psychiatric comorbid conditions. Medically monitored programs are also available for individuals with less complex conditions. They offer professionally directed evaluation and treatment in short-term settings for those with acute distress and moderate impairment, and long-term settings for those with chronic distress or severe impairment. Short-term rehabilitation offers rehab, learning lost skills, while long-term rehabs offers habilitation, learning new skills. Halfway houses offer residential treatment in a substance-free communal or family environment that provides opportunities for independent growth. Individuals continue the work started in other treatment programs, usually in a long or short-term residential rehab center. The focus is on extending the period of sobriety, getting case management assistance in addressing educational, economic, and social needs, and integrating new life skills in a solid, modeled recovery program. Most residents live in these halfway houses but work outside. Other housing. Opportunities for community reintegration are also available in supportive housing units that are not part of treatment. 3-quarter-way houses, therapeutic communities, and housing programs offer drug-free living environments, peer support, and classes to assist or remediate skills needed for daily living. Residents usually attend some type of outpatient substance use treatment to continue in their recovery program. Partial hospitalization program is an intensive form of outpatient programming for those individuals who do not need a 24-hour residential treatment, but who benefit from a structured treatment setting. Partial programs tend to run 5 days a week for about 6 hours a day with planned programming. This combination of psychotherapy and educational groups does not require the individuals to have previous treatment experience. Participants may live in some type of supportive housing program or in an independent house. Medication management is available, but it is not usually medically monitored or managed in this setting. Intensive outpatient programs, or IOP. An alternative to a partial hospitalization is an IOP. This is a non-residential program, highly structured with scheduled treatment groups, and at least one individual session regularly. Medication management is usually available, but will not be monitored. Participants attend at least 3 days a week for about 3 hours per day. Outpatient treatment. The least intensive form of substance use treatment is outpatient. Treatment may be a mix of individual sessions and educational or psychotherapy groups as determined by the individual's needs and its treatment goals. It is structured, drug-free, and non-residential. Programming consists of not more than 5 contact hours per week. Web-based interventions are also available for self-paced, anonymous, collective participation in treatment efforts. Alcoholics Anonymous. AA was founded in 1930 and is the oldest and best known of the 12-step programs. Anyone with a desire to quit drinking or using substances is welcome to attend meetings. Individuals learn how to be sober through the support of other members and the 12 steps. In most suburban and urban areas, meetings can be found every day and around the clock. Meetings are even available online and are structured for confidentiality and anonymity. Family members and other support are often welcome. The 12-step model has been adopted worldwide. Specific groups may focus on specific addictions and/or include specific populations such as women, men, and certain groups. The size of meetings range from small, around 15, to large, more than 50. There are also meetings to address the special needs of family and significant others, such as Al-Anon for friends and family members of alcohol abusers, Alateen for teenage relatives of alcohol abusers, and Nar-Anon for family and friends of drug users. Relapse prevention. To maintain long-term sobriety, each individual must prepare for and anticipate the possibility of relapse. This includes identifying potential triggers to substance abuse, learning skills to regain abstinence in the event of use, and adopting healthy coping, identity, and stress management skills to address triggers before they threaten sobriety. Advances in technology have expanded options for maintaining long-term sobriety. Applications for smartphones, for example, offer a way to monitor behavioral patterns for relapse clues. And that is it. That concludes Chapter 22. Bing, bang, boom.